Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Vazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi everyone. Welcome to another episode of the Egg Whisperer Show. Tonight's topic is how to prevent future pregnancy loss, and I'm so excited because a special friend of mine and fertility expert and miscarriage expert, Dr. Laura Shaheen, joins me tonight. Hi, Dr. Shaheen.
Hi, Amy. I'm so excited to be here. Thank you.
You're very, very welcome, and we are so thrilled to have you live with us on tonight's show. So why don't you tell us a little bit about yourself, about your practice? Go ahead.
Sure. So I am in Seattle. I'm in a private practice at Pacific Northwest Fertility here in Seattle. And I've been up here for about almost 8 or 9 years. Mm-hmm. And I did my fellowship training at Stanford. And when I was there, my mentor, Ruth Lottie, was starting her own Center for Recurrent Pregnancy Loss. And I learned a lot being in the right place at the right time. And I really wanted to bring this knowledge to Seattle and really help the people here.
So one of the reasons why I wanted you to be a guest on this show is because you just wrote a book. Can you tell us a little bit about it?
Sure, absolutely. So it's a book. It's called Not Broken, An Approachable Guide to Miscarriage. And I did this as a way to help people. Mm-hmm. I've seen a lot of patients with recurrent miscarriage and pregnancy loss, and so many people come to me feeling broken. Yeah. They feel that their body is failing them, that their body is rejecting the pregnancy, and that's something that they've done wrong. And science really doesn't support that. But there's not a lot of great information out there, and in the world of Dr. Internet, I needed and I felt a passion to get something out to people that is evidence-based, but hopeful and readable and reality.
And it's in your title, Approachable. I love your book. I read it before it was even published, and I recommend it to my patients, and I think it's a great guide because I think even doctors don't necessarily know, doctors who aren't in our specialty don't necessarily know exactly what to do for patients, and I think this is so just spot on for everybody, whether you're an OBGYN, a general doctor, or a patient who's going through this. So I follow you on Instagram, and I love your posts. They're fun, and you just went on a family vacation as well as a book tour. So can you tell me a little bit more about your book tour?
Sure. So I don't know if you can really call it a book tour. It was just an idea I had as a way to increase awareness for miscarriage and people with recurrent loss. And I want my book to get out there because it does have good information. I'm very humble, but I believe it's got very accurate information, but it also remains very hopeful. And I was going on a vacation to London and Paris, and I just had this idea, why not share my book with people in Europe? And so I took several copies of my book with me. I wrote in the front of each copy just who I am, why I wrote the book, and that I want to give this to people. And I left it at some pretty famous spots, like the Tower of London, Big Ben, the Eiffel Tower, train stations, and I just really had a lot of fun with it.
Did you ever leave the book somewhere and then someone came after you and said, Madame, your book?
Well, I did actually leave it, and I saw someone who was cleaning the train station pick it up.
Yeah.
I don't know if it went into the trash right after that, but I did actually see someone pick it up, and I'm just going to leave it at that.
Yeah, that's so fun. So I would say that the number of questions we got was overwhelming for this show. So I'm certainly going to do my best to answer everybody's question, but since you're here, let's just talk about all the questions that people have related to something that's so common and part of the human condition, which is miscarriages. First of all, I hate the term miscarriage, don't you?
Yes.
Just the thought that somehow we missed carrying something or we lost a pregnancy. I hate terms like cervical incompetence. Like these words just make us feel so bad about ourselves. So while you and I are smiling and we're having a really lighthearted conversation about this, we certainly both know that it's not all smiles, and certainly there are a lot of heartbroken people out there. So we're hoping that this show definitely helps you out there deal with something in a way that can make this a little bit better. So let's get to the first question. So first question is, what's the difference between a biochemical pregnancy, blighted ovum, and a miscarriage? What do you tell your patients, Dr. Shaheen?
Absolutely. Very common question. So a miscarriage in medical literature is an established pregnancy that can be documented with an ultrasound or with a tissue diagnosis that doesn't come to term. But that doesn't fit so many people's personal experiences, with home pregnancy tests being so sensitive now, and many times blood tests being positive or a urine home pregnancy test being positive, and then a menses or a period happening a little bit later. Those are pregnancies, you know, egg and sperm fertilized, the cells started dividing, embryo implanted. That is a pregnancy, but the medical community and the experts don't really know exactly what to do with it yet. And so in expert opinions and in textbooks, it clearly states that a miscarriage is a clinically recognized pregnancy that doesn't continue. And it's very often that biochemical miscarriages, or that means positive pregnancy test, but doesn't get to the point where you can see anything on ultrasound, is left out of the information and guidelines.
Yeah, and certainly that's so frustrating for our patients too, to have those types of biochemical pregnancies. So,
absolutely.
So, and then the blighted ovum, like, what's the difference?
Oh, sure. So a blighted ovum just means that the pregnancy gets to the point where you can see a gestational sac on the ultrasound, so a pelvic ultrasound, and you can see something in the uterus, but it really stops developing before the pregnancy gets to the point where you can see a heartbeat or really see a fetal pole.
Yeah, and so for our patients who are going through things like this, you and I tend to see patients really early in pregnancy. Positive pregnancy tests, we follow the levels, maybe 2 or 3 times, maybe then a week later before we can do a patient's first ultrasound. But a lot of times when patients find themselves pregnant, they go to their OBGYN at 12 weeks of pregnancy, and then they see that gestational sac and they're told that it's a blighted ovum, and that can be so confusing. But you and I both know that it could just mean that the pregnancy stopped growing and there was indeed a fetus there, but by the time you got to the doctor at 12 weeks, it wasn't there. So the body can naturally take care of this. So another question that someone emailed, I'm going to read it now. What can I do to increase my chances so a miscarriage doesn't happen again? What would you say?
Absolutely. Well, I think something that's important is to get an evaluation. So textbooks often will say you need to have 3 clinical miscarriages before it's recommended to do an evaluation. But in 2012, the American Society of Reproductive Medicine really came out with new guidelines and said that, yes, for studies and looking for interventions that might help, you know, maybe classically we should say 3 miscarriages, but to start an evaluation for our patients and for people who are struggling to complete their family, it's okay to start an evaluation after 2. And that's a big deal for patients.
It is. I can't imagine telling someone, you need to go through something really horrible 3 times before I can help you. It's cruel. And the other thing I've heard patients get told is, I'm not going to test your pregnancy for the chromosomes until you have 3. And that's actually so inaccurate and not true. So if you find that you've had a miscarriage, you can do genetic testing of the pregnancy. For example, the ANORA test, doing some sort of microarray analysis, can actually tell you what's wrong. You don't need to wait until it's happened 2 or 3 times to find out exactly what happened. Because if you know the pregnancy was genetically abnormal, then you know what kind of workup to have. Don't you agree?
Yes, and having a chromosome imbalance or a genetically imbalanced embryo is the most common cause of first trimester miscarriage. And a lot of reasons that providers are hesitant to do the test is they're worried about cost to the patient. They're worried that it might not change future steps like evaluation and treatment, but I argue that it will. And then the traditional way of doing genetic testing of a karyotype in a lot of hospitals really relies technically on growing cells.
Right.
And so if you use that technology, it can be up to 60% of the time you don't get an answer.
Exactly.
And so what you mentioned is the type of test you can use new technology. You can even do testing on, you don't have to grow cells anymore. You can do testing on, something that's been in pathology for a while.
Right, so like a paraffin block. So I tell patients it's like having a CD case, right? So patients come to me and I say, I really wish that I could have learned from those previous pregnancies. And they're so surprised when I say, I can actually go back and grab a slide, send it to this genetic testing company, and they can extract DNA. It's almost something like it's out of CSI. And patients, they want answers. They want to know why they suffered through that loss or why that loss occurred, so that hopefully that information can help guide us in the future. Okay, so another question, and this can be so confusing where patients show up and they have no signs that the pregnancy stopped. So the question is, why didn't my body give me some warnings like bleeding or cramping?
That's such a good question. And for most of the time, the body will do that. Everybody's body is just different. So if the pregnancy stops developing at about 6 weeks, some people will get the message as far as bleeding or cramping or feelings that change at 6 weeks, 7 weeks. It can take up to 4, sometimes even longer, 4 weeks after a pregnancy stopped developing,
right.
For our bodies to get that message.
Right, that's so true. And then this is a question about diet. How does diet play a factor in all this? Would being gluten-free, for example, help? And I'm sure you get those questions just as much as I do.
Absolutely. So there's still so much that we have to learn, but there are some small studies that are suggesting that if people really do have celiac disease and they do have miscarriages, if they change their diet and they go to gluten-free, that might help decrease the risk of another miscarriage. But those are a certain subset of patients, so that doesn't mean everybody should go out and all of a sudden go gluten-free. So it's hard to take information on somebody that truly has a disease and they change an outcome and have an outcome. That doesn't mean that's going to work for everyone, but it's true. Something to investigate.
Yeah, because a lot of people, they just think if they go gluten-free, it'll fix the problem because it's something that they, let's say, read online. But it's certainly not the answer for anybody. But if you have, let's say, celiac disease, then potentially it could help. Okay, so are there any supplements you would recommend taking to help with egg quality for patients who've had miscarriages?
Sure. Well, again, I still think we have a lot to learn. I think a really interesting resource is Rebecca Fett's book. It's all about the egg. She does go into the animal studies and on a molecular level, learning about certain supplements that might affect DNA replication, and that's a big part of a healthy established pregnancy. So she has kind of gone into some of the studies there. I think we have a lot to learn to go from animal studies and what we're seeing with mice to seeing what's going on with humans. But things that she's talked about is some of the antioxidants might be helpful. Coenzyme Q10 is considered possibly helpful. But I think a really good prenatal vitamin, and I often have patients look for one that has something called methylated folate because it's often easier for our bodies to process, and we know that's important for preventing neural tube defects. I try to focus on that. I think also focusing on a healthy lifestyle and doing all those things that we need to do and trying to get your nutrients from a really good diet. I think it's a little bit too easy to think that you can just go to the store and buy a pill and that's going to make everything better. But I want that too. It's not there yet.
Right. And I actually, I brought a copy of your book, your other book. And so you actually do an awesome job going through the literature as to all the supplements that are out there and what benefit they could possibly have. So patients ask me all the time, does acupuncture help? Why would it help? And I love this book. You and your co-author did an incredible job. And I think you also do a good job going through all the supplements as well, like CoQ10, melatonin, and all the data as to how it may improve egg quality too. So thank you for writing that book. So awesome. Okay, so now, are there blood tests for clotting or autoimmune disorders? So tell me.
Yes, there are tests, but it might not make a huge difference to do a lot of those tests, and it might not make a huge difference to act on the results of those tests.
Yeah.
So this is a huge controversial topic.
Yeah.
It plays into women's feeling guilty and blaming their body for miscarriage in order to focus on immune issues or blood clotting issues. Okay. And so it's a big part of my book. There's a whole chapter on this. 20 or 30 years ago, there was a huge push to focus on blood clotting issues and causing miscarriages, but that has not been proven to really cause first trimester miscarriages. And people who have these blood clotting disorders that we look for don't necessarily have a higher chance of miscarriage. And even when they're treated with anticoagulation, they don't have a significantly lower chance of miscarriage.
Right. So Dr. Shaheen, the sun is setting where you are in Seattle. Yes. I'm sure it's absolutely gorgeous outside your window, but I'm missing your face. That's awesome. How does that look? Oh, that looks gorgeous. Yeah, here, turn your camera just a little bit more. We don't want to miss any bit of you. Turn your camera just a little. Ah, beautiful. That's perfect. Thank you. Thank you. We'll do another sound check. Hi, Laura. Can you hear me?
Yeah.
Okay, perfect. Okay, so next question. When should I get evaluated for miscarriages, and who does that kind of evaluation?
Great question. So I think that you should ask for an evaluation after 2 losses. And some primary care doctors, OBGYNs, might be able to do it. Usually it's people who subspecialize. So a traditional reproductive endocrinologist like Dr. Amy or myself would really focus on recurrent miscarriages. And then some maternal fetal medicine physicians. So those are perinatologists or people who focused on high-risk obstetric issues. They might be able to do a great evaluation as well.
Okay, excellent. So here's another question. Along the same lines of what we've just been talking about, someone emailed and said, I'm 33 years old. I've had 3 consecutive miscarriages due to chromosomal abnormalities. All tests are normal. My karyotype, my husband's karyotype, coagulation studies, endocrine. Would it be better to turn to IVF with PGS? And is it possible to have a healthy baby naturally without it? I know I'm not giving you too much information because this was an emailed question, but can you answer that question for us?
So that's an excellent question. So this person knows exactly why she's had those 3 miscarriages, because whoever is helping to take care of her is testing the pregnancies, and she knows it's not her body rejecting her husband's sperm or her body rejecting the embryo, that it's the egg and sperm. When they came together, there was just not a good match of chromosomes. Right. And so her options are 2 extremes. Right. One is to just try again. Because the very next time she tries to conceive, her chance of a healthy pregnancy can be as high as 60, maybe even 70%. All it takes is a good egg and a good sperm. Right. The other option that she has is, instead of this trying and miscarriage and the fear that she has putting herself out there again, is she has the option of screening the embryos before she even conceives. So we do have the ability of taking eggs out of the body with IVF or in vitro fertilization, fertilizing them with sperm, watching the embryos develop. I love that. And when the embryos are ready, we can actually test them. And we could only put back an embryo that has the right balance of chromosomes. Right. So instead of trial and error, it could be considered more efficient to screen the embryos outside of the body.
And it's certainly if she hasn't had kids yet too, it might help preserve her fertility as well if she's starting here at 33, so that when she's ready for baby number 2, she potentially has another normal embryo for her.
Exactly.
Yeah. Yeah. Okay, so now these questions have more to do with like the procedures related to, you know, once you've had a miscarriage, it's been diagnosed, what do you do? So people, someone has asked me this, do you double check to make sure there is a heartbeat before you do a DNC procedure?
Yes, we do that routine in our clinic. We have an ultrasound right in the procedure room, and it's absolutely.
Good. And then do you do your DNCs, do you do those procedures under anesthesia as well?
So we do. Every clinic is different, but we just have an IV that gives patients medication, and they go to sleep. It's very brief. They're not intubated, but they're asleep. They don't remember anything. They don't feel anything, and we take really good care of them.
And then another question: how long should a patient expect to be out of it after a DNC procedure?
When you say out of it, do you mean recovering from the medication, like the sedation?
Exactly.
So we use a medication that wears off very, very quickly. So they're in our office for about an hour, hour and a half total, and they go home feeling okay.
And can the patient drive herself home?
No, because they've had anesthesia, we recommend she has somebody to drive her home. Yes.
And then how long do you tell your patients the physical recovery will take after a procedure like this?
Yeah, everybody's really, really different. Some people have a little cramping that day or the next couple of days. Some people will still have bleeding. But usually people rest and relax that day, maybe consider taking the next day off. But I do have a lot of patients that go right back to work the next day.
And then do you tell them to have any restrictions on their physical activity, like exercise?
What I say is see how you're feeling. I wouldn't use tampons or have intercourse or anything in the vagina for at least about a week, just because your body is healing and recovering. And I wouldn't do any heavy exercise for about a week or two, but walking, light exercise, light weights, as long as you're feeling okay, just try it and be very gentle.
Yeah. And if you've documented a miscarriage and the patient was on progesterone, what do you tell them to do about their progesterone?
Sure. So you're saying that somebody's taking progesterone and they come in for an ultrasound and we see that there's not a heartbeat.
Right.
One option is to stop the progesterone and that might help their body get the message that the pregnancy is no longer developing and they might have a natural miscarriage. But if somebody really wants to have the DNC, they're nervous about having a miscarriage at home. They don't want that to be a surprise, and they want to have a procedure, then we'll have them continue the progesterone until that procedure.
Yeah, exactly. And then they stop it right after they basically stop it after the procedure until they're ready to try again, right?
Yes.
Okay, good. And then when you screen the embryo in your clinic, how long do you tell patients it'll take for the results to get back?
I say about 7 to 10 business days.
And then do they come back to your office to review the results and do a post-op check or post-miscarriage check?
We actually, we see them about 2 or 3 weeks later, kind of closer to when probably their natural period might be coming. But we call them with the results as soon as we get them because we know that they're anxious to hear those results.
Yeah, absolutely. And then I get this question all the time. I bet you get it all the time too. Is there any benefit physically to waiting longer than one period to start the process and try to get pregnant again?
It depends on when the miscarriage happened. If it's in the first trimester, there's really no physiologic benefit from waiting another period. If someone has a significantly later loss in the second or even third trimester, then it might be better to let the body recover and let the uterus kind of get back to its where it needs to be to have the best chance of a good pregnancy.
Excellent. Okay, so I have another emailed question. This is a patient who had 2 miscarriages and she's now pregnant. And typically what happens is everything goes fine until her 6-week ultrasound. She goes in for the ultrasound, then she starts to cramp, bleed, and then at 7 weeks she's miscarried. Okay? So right now her HCG levels went from 187 to 494. She's bleeding and cramping again. She works in a store. She's very confused. Would you take her out of work?
Oh gosh, I wish it would be that easy. Right. It's so hard because there are people that have very strenuous jobs or get pregnant in the middle of war and famine and very emotionally and physically draining situations, and the pregnancies are just fine. More than likely, the miscarriages are from a chromosomal issue that that working has no control over. And patients call me bleeding all the time, and I said, listen, if there was a medication I could give you, if there was a procedure I could do, if there's anything that I could do, if bed rest worked, of course I would tell you to do it. But it's not that easy.
Of course. And another question is, would fibroids cause a miscarriage?
Sometimes.
Yeah.
So fibroids in and of themselves are very common. Some studies say up to 50%, 50, of women have fibroids, which are, they call them just benign tumors, kind of like these little muscle balls in the uterus. And so not all fibroids cause miscarriages, but it depends on the location and the size of the fibroids.
Right.
So we believe, as some studies suggest, if there's a fibroid that's inside the uterine cavity where an embryo would implant, we call that a submucosal fibroid. It makes sense that if the embryo were to implant on that fibroid, there might not be a very good blood supply, and it could be a cause of recurrent miscarriage. And then people really are trying to figure out if there's a size connection with the size of a fibroid and miscarriages, and the jury is still out on that. Some people worry if they're over 5 centimeters. Other studies say, oh, it doesn't matter unless they're over 8 to 10. So I think you have to take the whole person into account and look at everything else, and then really weigh the pros and cons of taking care of fibroids, because it requires surgery. And so you really want to think through it.
And what about aspirin? When you go online and go to Dr. Google, it's like aspirin seems to cure everything. What do you tell your patients about aspirin and miscarriages?
Sure. So again, if it were that easy, that would be great. And aspirin, okay, so big studies looking at whether aspirin helps with unexplained recurrent miscarriage do not support it. They say it's not helpful. Knowing that, I know all of my patients are taking it, and I don't think that it's really harmful for most people, as long as they don't have an allergy or a GI issue that aspirin can upset. And aspirin is the first-line treatment for the one immune issue and blood clotting issue that we do look for with a recurrent pregnancy loss. It's something called antiphospholipid syndrome. So if someone is diagnosed with that, one of the first-line treatments is to take aspirin. And so it's definitely something to think about. It's not super simple. And please, if you do take aspirin, make sure your provider is aware. And it's something you can easily pick up at the drugstore, but you should definitely take it under the care of a provider.
Awesome. Thank you. So I want to go through some fertility truths or myths. Okay. So I'm going to ask you a few questions here. That was all the emailed questions that we got. So thank you for going through all those questions with us. Okay. So fertility myth or truth? Having a miscarriage means you'll have a higher chance of future pregnancy. What do you say, Dr. Shaheen?
Both. So I want to be able to say that if you have a miscarriage, that means that you're more fertile. And patients ask me that all the time. And and what I think is, let's focus on the positive. I mean, I don't have a study that can say, like, yes, you'll be more fertile, but think about all the hurdles that you had to get through to get to that miscarriage, in that the egg and sperm liked each other and implantation happened. And so so that's really positive, and I want it to be encouraging, and so I'm going to say both. I'd like to err on the side of truth, because that might make people feel more hopeful, and that's kind of the whole point, is to keep trying.
Okay. So next one, doing IVF, and we kind of talked about this a little bit already, with PGS, which stands for pre-implantation genetic screening, can decrease chance of miscarriage.
Yes, for a lot of people, but not for everyone. So the biggest limitation of IVF is we're only working with the eggs and sperm that we have. So if someone has very poor ovarian reserve, or in an IVF cycle we might only get 1 or 2 eggs, it's really hard to justify using all of those resources when it might not be successful. But for someone else that could just do 1 cycle and maybe have lots of embryos to test, yes, it could. Another way to put it is, IVF really is considered more efficient. It's screening. It's sort of, you're not trying just with one egg each month. If you could do IVF and get 12 eggs, that's like a year's worth of trying. So that's great.
Right.
And then your body isn't doing the selecting and having to go through another miscarriage. The selection is going on in the lab.
Right.
And so if someone is, 40 years old and they were to conceive naturally, the miscarriage rate is close to 50%. Maybe even higher if they've had miscarriages before. But if someone's 40 years old and they do IVF and they have an embryo that tests okay to transfer, we call that a euploid embryo, and they transfer that, the miscarriage rate is less than 10%.
Yeah. What
so
a
that's
big reduction. That's huge. That's really powerful. And that's something that you offer.
Yes,
you do that in your clinic. That's what you do every day, all day.
I do, but I also am humbled by the fact that some of my patients who do IVF for this reason transfer a euploid embryo, and 10% of the time they have a miscarriage.
Yeah, it's so heartbreaking.
So it's not perfect. It's so much better than what we were doing 10 years ago, 20 years ago, which was just patting people on the head and saying, "Good luck, honey." But it's, it's really a lot. It's a very thoughtful decision, and you should have a really good provider that walks through the pros and cons.
Right. Okay, so next one. Egg freezing can help prevent future miscarriage. What do you think?
Well, the most common cause of miscarriage is from a chromosome abnormality in the embryo, and it's older eggs that have a higher risk of not doing the chromosome work. Correctly. So if you can freeze eggs when they are younger, they are going to have a lower chance of resulting in embryos that will be a miscarriage. So I talk about this all the time. There is a huge connection, and it's a circular relationship between age, diminished ovarian reserve, miscarriage, recurrent miscarriage, and they're all tied into the fact that if the egg is not able to do all of the genetic work that it needs to correctly, it's going to result in an embryo that is not going to be a healthy pregnancy. And so it kind of ties all together in that way.
It definitely does. It definitely does. Okay. So you did such a good job in your book addressing the emotional support and emotional needs of patients. So what kind of resources do you have in Seattle for your patients?
Yeah, we have a wonderful network up here. We have about 4 or 5 Resolve groups, which is Resolve is a patient-run fertility network that's actually national. They have a wonderful website with, and you can put in your zip code and you can, or city, and you can find if there are any Resolve support groups in your area. We have about 4 or 5 in Seattle, and we actually have some miscarriage support groups that are through Resolve, but also through some churches up here too, and they're not faith-based, and so that's another resource. And then some women's hospitals, some women and children's hospitals often have support groups for people with loss, and so that's another resource. And I think individual counseling can be really wonderful and appropriate. Some wonderful books that are out there. There's a really good app called FertileCom. I don't know if you've done that. It's a free app. You can download it, and it really walks you through stressful situations and mindfulness ways, like breathing techniques and wonderful ways to kind of help you get through a stressful situation. So there's so many different ways to find support. Sometimes yoga for fertility. Everybody's so different that we talk about lots of different options.
Right. So where can we get your book?
Great. Right now it's on Amazon, and you can order it in print form or on the Kindle.
You sent me a copy, but I read it on the Kindle, so that was it was very easy to. It was a great read. So thank you for that. It was informative, and it's a wonderful book.
Thank you.
So let me just see if there's anything else I wanted to ask you tonight while you're here. Tell us about your clinic location and where people can find you.
Oh, sure. So my clinic is Pacific Northwest Fertility. It's here in Seattle. We have our main office is right in Seattle, and then we have another office where we see patients sometimes out in Issaquah. And we have a wonderful website. It's a good resource. And then for me, I really enjoy writing. I obviously talked about my 2 books, but I really enjoy writing blogs and for the Huffington Post. And when it's really become a passion, because it's a way that I can get information to people. And so I do have a website, just laurashaheen.com, and if you can see other writing and things that I've done there.
Yeah, well, thank you for all you're doing to help women deal with something that's really, really horrible, maybe not seem as bad because they know that they have someone like you to support them. So is there anything else you want to tell our audience tonight before we end the show?
Yes, I want people to hopefully leave the show and to read my book and get the message to try and stay hopeful that no matter what test you do, no matter what treatment you do, if you can just try again, most of the time, everything's going to be okay. So I know we talked about interventions and I know we talked about tests, but if somebody doesn't do a single thing, all it takes is the right egg and the right sperm, and just find that network, find the people that are going to support you and help you keep trying.
That's great. Well, thank you again for your time. Thanks for being on our show, and looking forward to seeing everyone next week for another episode of the Egg Whisperer Show. Have a great night.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Avazadeh
And you have yet another success story.
just launched by an East Bay fertility doctor.